I need to understand a bit more about the anatomy of the kidney. So, if you could do that, and perhaps talk a bit about the functions of the kidney so we can understand what might be going wrong.
The kidney's anatomy is key to understanding its functions and what fails in renal failure. Each kidney is bean-shaped, about fist-sized, sitting below the ribcage on either side of the spine. Inside, the cortex, outer layer, and medulla, inner layer, house around 1 million nephrons, the functional units. Each nephron has a glomerulus, a capillary network for filtration, Bowman's capsule collects filtrate, and tubules, proximal, loop of Henle, distal, collecting duct that process the filtrate. Blood enters via the renal artery, gets filtered, and exits via the renal vein. Urine leaves through the ureter to the bladder. Kidney functions include filtration. Nephrons filter blood 180 liters a day, removing waste like urea and excess water, forming urine. Fluid electrolyte balance. Reabsorb water, sodium, and potassium. Excrete excess to maintain blood volume and osmolarity. Acid-base balance, excrete H plus ions and reabsorb bicarbonate to keep blood pH at 7.35, 7.35. Hormone production, release erythropoietin, EPO for red blood cell production, and renin for blood pressure regulation. Activate vitamin D for calcium balance. In renal failure, these go haywire. Filtration drops, causing waste buildup, high urea, creatinine, fluid balance fails, leading to edema or dehydration. Electrolytes like potassium spike, risking heart issues. Acidosis worsens from poor H plus excretion. EPO and vitamin D productions tank, causing anemia and bone problems. Acute kidney injury, AKI, might stem from sudden nephron damage, e.g. toxins, while chronic kidney disease, CKD, involves gradual nephron loss, e.g. diabetes. Want to dive into nephron mechanics or specific failure impacts?
That's a good introduction. Okay, why don't we, and I'll remind you, as general rule, let's answer with the least amount of words possible while getting our point across using our words effectively and efficiently. That was great. So let me ask you how we assess kidney function in the first place. Mentioning glomerular filtration rate, creatinine, etc., etc.
Kidney function is assessed mainly via glomerular filtration rate, GFR, blood creatinine, and urine output. GFR, measured in millimeters per minute, shows how much blood the glomeruli filter. Normal, 90-100. High creatinine, a muscle waste product in blood, signals low GFR, as kidneys aren't clearing it. Normal, 0.6, 1.2 grams per DL. Blood urea nitrogen, BON, normal, 7 to 20 grams per DL, also rises with poor filtration. Urine tests check protein or blood, indicating damage. Low urine output, plus 400 millimeters day, suggests failure. GFR is estimated using creatinine levels, age, sex, and weight. Want specifics on GFR calculation or test interpretation?
Well, that's good, and we've talked a lot about it in other episodes too. Okay, let's talk about the methods to determine GFR. So we have isotropic methods. Talk to us about CREDTA. We have inulin. Talk to us about this, and let's talk a bit about the creatinine clearance too.
Glomerular filtration rate, GFR, is measured directly or estimated CNS XML, in-dot XML, to assess kidney function. Direct methods use episodic tracers like CRA51 EDTA or inulinin. CRA51 EDTA, a radioactive marker, is injected. Blood or urine samples track its clearance, giving precise GFR, normal, 90-100 and millimeters per minute. Inulin, a gold standard, is filtered but not reabsorbed. Its clearance matches GFR but requires continuous infusion, so it's less practical. Creatinine clearance estimates GFR by measuring creatinine, a muscle waste product, in 24-hour urine and blood. Formula: urine creatinine times urine volume divided by plasma creatinine, adjusted for body surface area. Normal creatinine clearance is 90-130 millimeters per minute. Lower values signal kidney issues. It's simpler but less accurate due to creatinine secretion by tubules. Episodic methods are precise but costly. Creatinine clearance is common despite variability. Want more on test limitations or estimation formulas like eGFR?
No, this is good. Explain to us the difference between glomerular filtration rate and estimated glomerular filtration rate.
Glomerular filtration rate, GFR, is the actual rate kidneys filter blood, measured directly with tracers like CRA51 EDTA or inulinin, 90, 120 millimeters per minute in healthy adults. Estimated GFR, eGFR, is a calculated approximation based on blood creatinine levels, age, sex, and body size, using formulas like MDRD or CKD-EP. GFR is precise but complex. eGFR is simpler, routine, but less accurate due to creatinine variability. Want to dive into eGFR formulas or their clinical use?
So, okay, so how do I measure eGFR and how do I measure actual GFR?
Actual GFR is measured by injecting a tracer like CRA51 EDTA or inulinin, then tracking its clearance in blood or urine over time, giving a precise filtration rate, 90, 120 millimeters per minute. It's complex and costly. eGFR is estimated using a blood test for creatinine plugged into formulas like MDRD or CKD-EP, factoring in age, sex, and body size, providing a quick, routine approximation without tracers. Want details on the formulas or test procedures?
I see. That makes sense.
Glad it's clicking. What's next on the renal failure track? Ready to dive into something specific?
Let's talk a bit about
Cool.
survival in ESRD.
End-stage renal disease, ESRD, is when kidneys function at less than 10%, GFR less 15 millimeters per minute, requiring dialysis or transplant for survival. Without treatment, waste buildup, fluid overload, and electrolyte imbalances like high potassium become fatal within weeks. Dialysis, hemodialysis or peritoneal, filters blood, extending life years to decades, but with complications like infections or heart issues. Kidney transplant offers better survival, 80-90% 5-year graft survival, but depends on donor availability and immunosuppression. Lifestyle, comorbidities, and access to care heavily impact outcomes. Want to focus on dialysis types or transplant challenges?
So, in CKD, chronic kidney disease, do we have what's uremic cardiomyopathy? Do we have such things?
Yes, uremic cardiomyopathy is a real complication in chronic kidney disease, CKD. It's heart dysfunction caused by uremia buildup of toxins like urea due to poor kidney filtration. It leads to left ventricular hypertrophy, fibrosis, and impaired heart contractility, increasing heart failure and arrhythmia risks. Causes include toxin effects, fluid overload, hypertension, and inflammation, common in CKD. It's especially prevalent in advanced stages, GFR less 30 millimeters per minute. Managing CKD and dialysis can help, but it's tough to reverse. Want to dig into its mechanisms or treatment options?
That's good. Okay, let's talk a bit about clinical presentations of kidney disease, such as hematuria, proteinuria. And let's get a bit more into the detail of proteinuria. So we have transient, which disappears on repeat testing, which I don't get. I guess it's just like temporary. How about orthostatic? when we stand. I also don't get that. Why would we have orthostatic? Why would be P proteins when we stand? And yeah, persistent, which makes sense. Explain to me the origins too, like glomerular, tubular, and overflow. So tubular would be not usually detected by dipsticks, and then glomerular has a high molecular weight protein, and then overflow, I don't know what overflow is. Yeah, so explain these things to us.
All right, let's cover clinical presentations of kidney disease, focusing on hematuria, proteinuria, and dive into proteinuria types transient, orthostatic, persistent, and their origins, glomerular, tubular, overflow. Hematuria, blood and urine, visible, gross, or microscopic. Causes include glomerular damage, infections, or kidney stones. It signals kidney or urinary tract issues. Proteinuria, excess protein in urine, detected by dipstick or lab types. It indicates kidney damage, as healthy kidneys filter proteins minimally. Now, the types. 1. Transient, proteinuria. Temporary protein in urine, disappearing on repeat testing, caused by stress, fever, or heavy exercise. It's benign, not indicating chronic damage. 2. Orthostatic proteinuria. Protein in urine when upright, but not when lying down. Common in young people, it's benign, likely due to posture-related pressure changes in kidney blood flow. Not stunned by blood pressure, but tied to standing's effect on filtration. 3. Persistent proteinuria. Constant protein in urine, signaling kidney disease. It's serious, linked to glomerular or tubular damage. Origins of proteinuria. Glomerular. High molecular weight proteins, like albumin, leak due to damaged glomerular barriers, common in diseases like diabetic nephropathy, detected by dipstick as albumin is abundant. Tubular. Low molecular weight proteins, like beta-2 microglobulin, aren't reabsorbed properly by damaged tubules, seen in tubular injury, often missed by dipsticks, which mainly detect albumin. Overflow. Excess proteins, like light chains and multiple myeloma, overwhelm kidney reabsorption, spilling into urine, not directly from kidney damage, but from overproduction elsewhere. In short, hematuria points to bleeding or damage, while proteinuria's type and origin reveal the kidney issue transient is fleeting, orthostatic is posture-related, persistent is chronic, with glomerular, tubular, or overflow causes. Want to zoom in on testing methods or a specific proteinuria type?
Tell me a bit about proteinuria in terms of how it's measured then. So we have a dipstick, but what other options do we have?
Proteinuria is measured using several methods, starting with a dipstick. A dipstick test detects albumin in urine via a color change, giving a rough estimate, e.g., trace, 1 plus, 2 plus. It's quick, but mainly catches glomerular proteinuria and misses low molecular weight proteins. Other methods include 24-hour urine collection, measures total protein excreted, normal, near close 150 milligrams day. Accurate but cumbersome. Spot urine protein to creatinine ratio, UPCR, compares protein to creatinine in a single sample. Normal, mere close 2 milligrams mg. Convenient, corrects for urine concentration. Albumin to creatinine ratio, ACR, measures albumin specifically. Normal, mere close 3.0. Sensitive for early kidney damage, like in diabetes. Lab tests like electrophoresis can identify specific proteins, e.g., light chains and overflow. Dipstick is screening. UPCR and ACR are standard for diagnosis. 24-hour collection is precise, but less common. Want details on interpreting these or their use in specific diseases?
So what's PCR? A low PCR, a high PCR, a medium one?
PCR, or urine protein to creatinine ratio, Measures proteinuria by comparing protein to creatinine in a spot urine sample, reported as mere close milligram protein, mere close mg, creatinine. Normal is 30 milligrams protein per mg. Normal is 2.2 milligrams mg, indicating minimal protein. Low PCR, around normal, suggests no significant kidney damage. Medium PCR, 0.2 2.0 milligrams mg, points to mild to moderate proteinuria, often early kidney disease or transient issues. High PCR, 1.0 milligrams mg, signals heavy proteinuria, typically from glomerular damage, like in nephrotic syndrome or advanced CKD. It's a convenient, reliable way to quantify proteinuria without 24-hour collection. Want to tie this to specific conditions or dive into ACR comparison?
I want to ask you about the difference between nephrotic syndrome and nephritic syndrome. I think nephrotic is about the nephron, nephritic is about the... I don't know, I always get confused. I want to understand how they differ too, like the urine cast, the proteinuria, how it differs, the hematuria, and the clinical features. But also, I'm a bit unsure about PCR still, to be honest.
All right, let's clarify PCR and then tackle nephrotic versus nephritic syndrome, covering urine casts, proteinuria, hematuria, and clinical features. PCR, urine protein to creatinine ratio, quantifies proteinuria in a spot urine sample, mere close milligrams mg creatinine. Normal is 2.2 milligrams mg, no issue. 0.2 2.0 milligrams mg suggests mild, moderate proteinuria, early kidney damage, and 2.0 milligrams mg indicates heavy proteinuria, serious damage, like nephrotic syndrome. Think of it as a snapshot of how much protein is leaking into urine, adjusted for urine concentration. Now, nephrotic versus nephritic syndrome. Nephrotic syndrome is partialness. Cause: damage to glomerular filtration barrier, e.g., minimal change disease, diabetic nephropathy. Proteinuria: heavy, 0.35 grams per day, PCR, 0.20 milligrams mg, mostly albumin, due to leaky glomeruli. Hematuria: usually absent or minimal. Urine casts: hyaline or fatty casts, lipids from protein loss. Clinical features: edema from low blood albumin, hypoalbuminemia, hyperlipidemia, risk of clots. Massive protein loss disrupts fluid balance. Nephritic syndrome. Cause: glomerular inflammation, e.g., post-streptococcal glomerulonephritis, lupus. Proteinuria: mild to moderate, 2.5 grams per day, PCR 0.2 2.0 milligrams mg, less severe than nephrotic. Hematuria: prominent, often gross, visible blood, with red blood cell casts in urine. Urine casts: red blood cell casts indicating glomerular bleeding. Clinical features: hypertension, oliguria, low urine output, edema, azotemia, high blood urea creatinine. Inflammation drives blood leakage and reduced filtration. In short, nephrotic, leaky glomeruli, tons of protein, swelling, no blood. Nephritic, inflamed glomeruli, blood and urine, less protein, high blood pressure. PCR helps quantify protein loss high in nephrotic, lower in nephritic. Clear now? Want to dive into specific causes or
No, to
lab
be
findings?
honest, I didn't understand at all. Could you summarize it in 2 sentences? I tried to understand, but everything flew over my head.
My apologies. I caught the Spanish, but let's stick to English as requested. Nephrotic syndrome involves heavy proteinuria, edema, and minimal hematuria from leaky glomeruli, while nephritic syndrome features hematuria, red cell casts, mild proteinuria, and hypertension from inflamed glomeruli. PCR measures proteinuria.
I don't understand how the names relate to what they are.
All right, let's clarify how the names nephrotic and nephritic syndrome relate to what they are. Keeping it simple. Both refer to kidney, nephron disorders, but the names hint at their distinct issues. Nephrotic comes from nephron plus otic, relating to a condition. It describes a syndrome where the nephron's glomeruli are overly permeable, leaking tons of protein, like albumin, into urine, 3.5 grams per day, high PCR versus 2.0 milligrams per ml. This causes edema, low blood albumin, and fatty urine casts, but little to no blood, minimal hematuria. The name emphasizes the nephron's role in massive protein loss. Nephritic syndrome comes from nephron plus itic, implying inflammation. It points to a syndrome where the nephron's glomeruli are inflamed, causing blood to leak into urine. Hematuria, red blood cell casts, with milder proteinuria, K of 3.5 grams per day, PCR, 0.2, 2.0 milligrams per ml, hypertension, and reduced urine output. The name highlights the inflammatory damage in the nephron. So, nephrotic and nephron protein leak, nephritic and nephron inflammation and bleeding. Clearer now? Want to revisit clinical features or PCR's role?
Okay. This is better, I understood more now. Okay.
Awesome. Glad it's coming together. What's next on the kidney failure journey? Hit me with it.
Let's talk about how we can keep patients psychologically well when they have renal disease. Tell me, yes.
Supporting psychological well-being in renal disease patients is crucial, as chronic kidney disease, CKD, or end-stage renal disease, ESRD, can trigger stress, anxiety, and depression due to lifestyle changes, dialysis, or transplant fears. Key strategies include counseling, cognitive behavioral therapy, or support groups help patients cope with diagnosis, treatment burdens, and uncertainty. Education. Clear info about CKD, dialysis, or transplants reduces fear and empowers patients to manage their condition. Social support. Connecting with family, friends, or peer networks combats isolation, especially during dialysis schedules. Mindfulness, relaxation. Techniques like meditation or yoga can lower stress and improve mental resilience. Multidisciplinary care. Nephrogenics, nephrologists, psychologists, and social workers collaborating address emotional and practical needs, like financial stress from treatment costs. Regular screening for depression, common in 20-30% of ESRD patients, ensures early intervention. Tailoring support to cultural and personal needs boosts effectiveness. Want to dive into specific therapies or how dialysis impacts mental health?
I want to ask you about trauma-informed care. What is this?
Trauma-informed care, TSC, is an approach to supporting renal disease patients or any patient that recognizes the impact of past trauma on their health and well-being. It involves safety, creating a trusting, non-judgmental environment, e.g., explaining dialysis procedures calmly. Empowerment, involving patients in treatment decisions, like choosing dialysis type to restore control. Sensitivity, understanding trauma, e.g., abuse, loss, may affect how patients react to CKD stress or medical procedures. Avoiding re-traumatization, using gentle communication and respecting boundaries to prevent triggering past trauma. For renal patients, TSC helps address anxiety or mistrust, common in ESRD due to invasive treatments like dialysis. Staff training ensures empathy and awareness. Want to explore how TSC integrates with psychological support or specific examples?
Okay. Let's talk a bit about having a trauma lens. What is this trauma lens?
A trauma lens is a perspective in healthcare, like for renal disease patients, where providers assume patients may have experienced trauma and adjust care to be sensitive to it. It means seeing behaviors like anxiety about dialysis or distrust of doctors as potential trauma responses, not just non-compliance. It involves asking, what happened to this patient, rather than, What's wrong with them? For CKD ESRD patients, a trauma lens guides gentle communication, respects boundaries, e.g., explaining procedures to avoid fear, and creates a safe, empowering environment to reduce stress and build trust. It's part of trauma-informed care, ensuring emotional safety alongside physical treatment. Want examples of applying it in dialysis settings or more on patient-provider dynamics?
That's so good. Okay, and lastly, what's non-adherence?
Non-adherence in renal disease means patients not following treatment plans, like skipping dialysis, missing medications, or ignoring dietary restrictions. It's common in CKD ESRD due to complex regimens, psychological stress, or financial barriers, and can worsen outcomes, like fluid overload or high potassium. Using a trauma lens, non-adherence might be seen as a response to fear or past trauma, not just defiance, prompting empathetic interventions like education or counseling. Want to dive into causes of non-adherence or strategies to improve it?
That's so good. Okay, so non-adherence is basically saying I don't want to go with the treatment.
Exactly. Non-adherence is when patients don't stick to their renal disease treatment plan, like skipping dialysis or meds, often due to stress, complexity, or other barriers. It's not just rebellion. It can stem from deeper issues like fear or trauma. Want to
Okay,
explore?
let's talk about renal replacement therapy now. Peritoneal dialysis too, and explain to me about this.
Renal replacement therapy, RRT, replaces kidney function in end-stage renal disease, ESRD, when GFAR drops below 15 millimeters per minute. It includes hemodialysis, peritoneal dialysis, and kidney transplant. Let's focus on peritoneal dialysis. PD. Peritoneal dialysis uses the peritoneum, a membrane lining the abdominal cavity, as a natural filter. A catheter is placed in the abdomen, and sterile dialysis fluid, dialysate, is infused into the peritoneal cavity. Waste, like urea, and excess fluid from blood diffuse across the peritoneum into the dialysate, which is then drained and replaced. There are two main types: continuous ambulatory peritoneal dialysis, CAPD, manual exchanges 4 or 5 times daily, each taking about 30 minutes. NASD, automated peritoneal dialysis, APD, a machine cycles dialysate overnight while the patient sleeps. PD is done at home, offering flexibility compared to hemodialysis, which filters blood externally at a clinic 3-4 times a week. PD suits patients with stable conditions but risks infections like peritonitis. It removes waste, balances electrolytes, and manages fluid, mimicking kidney rolls. Want to compare PD to hemodialysis or dive into PD complications?
I want to understand the difference between peritoneal dialysis and hemodialysis. And yeah.
Peritoneal dialysis, PD, and hemodialysis, HD, are renal replacement therapies for ESRD, but they differ in method, location, and lifestyle impact. Peritoneal dialysis, PD, uses the abdominal peritoneum as a filter. Dialysate fluid is infused via catheter into the peritoneal cavity, absorbs waste and fluid from blood, and is drained 4 or 5 manual exchanges a day or automated overnight. Done at home, offering flexibility, removes waste and fluid steadily. Risks include peritonitis, infection. Hemodialysis, HD, filters blood externally through a dialysis machine with an artificial kidney, dialyzer. Blood is drawn, cleaned, and returned via vascular access, fistula, or catheter. Typically done in a clinic 3-4 times a week, 3-4 hours per session. Rapid waste fluid removal but less frequent. Risks include low blood pressure or access infections. PD is home-based, gradual, and patient-driven. HD is clinic-based, intensive, and scheduled. PD suits independent patients. HD fits those needing closer monitoring. Want to explore patient suitability or complications for
That
each?
makes a lot of sense. Okay, well, thank you for watching this episode, guys, and I'll see you next time.